This is Blood and Cancer, the official podcast of MDH Hematology Oncology. I am the voice of MDH Podcasts, Nick Andrews. And welcome aboard to episode 76 of Blood and Cancer, where we bring you interviews with leaders in the field of hematology and oncology, inspiration and chit-chat. Please welcome the editor-in-chief of MDH Hematology Oncology, Dr. David Henry, who's going to be leaving us soon for the Jersey Shore. He's going to go on vacation. And I just heard that Dr. Henry likes to make fun of the rest of us who are traveling after the 4th of July weekend and point fingers and say, haha, I don't have to go home.
And that's exactly right. What I do is, of course, the weekend is the holiday. And if you go down and back up, especially if those know the East Coast and Jersey Shore, it's very heavy traffic. So I thought, well, I'll take my week and make it Wednesday to Wednesday. So I can sit on the porch with my coffee or a cocktail and watch the cars go by.
Yes,
so that's coming up.
Yeah, and you're going to, of course, listen to back episodes of Blood and Cancer that you may have forgot about.
Just like all day long on the beach.
That's exactly right. What better time to learn about the latest in clinical hematology?
The beach is actually tricky for me because people know what I do. And I'll be there with my book and, of course, my sunscreen and my hat, and I'm all covered up, and I start reading, and someone comes and go, hi, how you doing? Is this a melanoma? Take a look at that. And so I really have to hide. I got to find a better way this year.
I imagine that you and perhaps professional athletes get opinions from people the most on the Jersey Shore. It's like, well, what do you think about this? No, I don't know. Call your doctor is the correct answer. So we got a big episode this weekend. Usually the way this works, and most people who are listeners to this podcast or any podcast understand that you want to work 2 or 3 weeks ahead of time. In this case, we just did this interview only a few days ago. We wanted to drop it immediately for 2 reasons. One, the timeliness of the meeting, and 2, because it was just really good. We needed to get it out there because it was timely, but because we thought it was important and we wanted to get it out. And that meeting is, of course, EHA.
We really enjoyed this one. Professor John Gribben, who couldn't be more, he's very well known and does an enormous amount of speaking and research. He's the current president of the European Hematology Association, EHA. They just had their big meeting. Of course, it was virtual. Supposed to be in Frankfurt. It was virtual. And we were discussing how ASCO went here. And he said, he was a little worried, but it went well there. And he was very good. We tried to cherry pick the meeting and look at the LBA, the late breaking abstracts, or the plenary session. And we did just that. And he, of course, right off the cuff, commented on each and every one, which I think you really enjoyed. Just to highlight, myeloma, is there another CD38 like daratumumab? There may be another antibody just like it. We talked about how to sequence in myeloma therapy. AML, whether it's MDS to AML or AML de novo, and in seniors, really difficult to give them the full therapy, R3 and 7, as we've been doing for years and years. So we talk about that with azacitidine and venetoclax. And then I thought most interesting, who among us doesn't see polycythemia vera, and we want to keep those hematocrits down to a certain level. Males and females a little different. Well, this abstract said, well, they need another option. Interferon now comes weekly, pegylated, low side effect, and it could be just another option instead of phlebotomy. And of course, we couldn't resist, and he had in his plenary and late-breaking abstracts something about COVID. Yeah. What is happening with COVID? Of course, the Hematology Association, in this case European, is just as vested in figuring this out as we are in the States. And there was some great information and research about what's happening in epithelial cells and why some people may clot more than others.
So I thought the research aspect of this was really interesting. Before we spoke to him and you did the interview, you said that a lot of EHA stuff is a lot more, we say bench to bedside. It's a lot more bench, but it seemed like there was some real practical information that you could sink your teeth into this time.
Going in, I thought exactly that. He was going to say things that I would have to write down and look up later and pretend I knew all about them, which I wouldn't because it was too bench and too technical. And he was very bench to bedside, very, very clinical, these abstracts that made prominent places on the meeting. And as he monitored as the president, really become very clinically useful.
And the last thing I thought was really interesting, and this is going to be something that we monitor going forward as we do these podcasts, is that everyone knows who's ever been to one of these meetings that it's a great place to blow off steam and perhaps run into colleagues that you haven't seen in a long time and see San Francisco or Chicago or New Orleans. But there is starting to become a pretty strong argument that perhaps it saves money, and doing a really good job on the broadcasts of the live virtual version of the meeting is something that people are really kind of starting to enjoy. And I think this is another instance of that.
Clearly, and he said that he listened in on ASCO to see what it would be like, and what they could learn. Their website, by the way, is really, we'll put that in the show notes, is really beautifully done and user friendly, and you can listen to some of these abstracts firsthand. We'll have those in the show notes, and of course, we may do some of this next year electronically and online, except the meetings in Vienna. So maybe you'll want to go.
Yes.
I know I will.
I'm working on that as we speak. I would like to go to Austria and Switzerland and Italy. That would be great. But we shall see. So the interview is coming up in just a little bit. Want to take the time to say you can email the show, podcast@mdedge.com. You can interact with us on Twitter @mdedgehemonc. And you can, of course, follow the rising superstar Dr. David Henry on Twitter. He's going to be verified soon, folks. This Twitter account was a baby a little while ago, and it is increasing exponentially. I think that you're about to become a social media influencer one of these days.
Wow, I can't wait for that designation.
One day at a time, of course. Well, Dr. Henry, I hope that you enjoy your vacation. I know you and I have some housekeeping stuff to do, but stay safe, enjoy yourself, and don't be too mean to those people that are stuck honking their horns.
I'll listen to them and look at their skin lesions on the beach. Enjoy this next one coming up, everybody. See you next week.
I'm your host, Dr. David Henry. You're listening to Blood and Cancer, a weekly podcast which airs every Thursday morning on iTunes or wherever you get your podcasts from. And our goal each week is to bring you interesting discussions with thought leaders and clinical scientists in hematology and oncology with kind of bench to bedside or practice changing or important to know information. And so I'm delighted today to be speaking with Professor John Gribben, who is coming to us from London. And I'm in Philadelphia, so the wonders of electronics continue. And he is professor of medical oncology at Barts in London, and he is the current president of the EHA, the European Hematology Association, whose meeting has just finished in virtual. John, is that correct?
Yeah, virtual meeting. So of course we had all hoped to be there and be in Frankfurt, but events overtook us, and we had a very short time from when we realized that maybe it will happen, maybe it won't. Will we have to scale down to, oh, this isn't going to happen at all, to put a whole virtual meeting together? So my hat's off to everyone in the office who really worked incredibly hard to try to bring this meeting together at very short notice.
So did it go very well? I attended the ASCO, as I was mentioning to you earlier, and it went well. There was a little bit of glitch in the beginning of 35,000 people tuning in, but then the IT people got it all together. Did yours work out electronically as well as you hoped?
Yeah, we had a little bit the same thing. We had been aware of what had happened to ASCO, and I had, like you and many others, gone into ASCO and found a little bit of glitches at the beginning, and we were assured by our vendors manning the website that it wouldn't happen. But you're right, we had more than 26,000 registrants into the meeting, and people going in and setting up the profile very definitely caused a little bit of hiccup at the very beginning on the very first day. But like we found at ASCO, the IT people got right on top of it and very quickly got things smoothed out. And I think thereafter things worked very well.
And one more question before we get into a few wonderful abstracts from the meeting. What do you think going forward, with any luck, we'll all be getting together? Maybe, the 1918 epidemic, people were still dying in 1920, so I'm hoping we get together next year. Do you think this format might continue even in some way, even when we get together?
I think that's a great quick question. And the issue is, will we ever go back to what we, will there ever be another 40,000 people meeting again, or is this the end of it? We are certainly planning to have our meeting next year in Vienna as planned, but we were already believing that probably we were going for a mixed economy model, as you might say, probably a live venue, but also because of the success of what we've seen on the online platform, doing a little bit of both. I think we'd all talked for years about, with more modern technology, did we really all have to be coming together? And no one wanted to be the first to do it. And COVID-19, of course, has made us all have to do it. And I think we've all seen that this can be successful, but none of us believe that it completely replaces what comes out of face-to-face interactions. A lot's going to depend on whether there's a second wave of the virus and what happens over the winter. And certainly in Europe right now, if I travel to overseas, I go into quarantine for 2 weeks coming back. So doctors are not going to be able to travel to meetings to have, for a few days, to have to take 2 weeks off work when they return. So all dependent on what happens. And hopefully we're going to see a return to normal next year or, by the end of this year. So we'll just have to see what happens in the fall when we see whether there's any of this predicted second wave that comes.
Well, if you keep picking these wonderful cities, Frankfurt, Vienna, we're certainly going to want to try and get there. So I'm marking my calendar. Well, let me begin then on some of the content we wanted to discuss that came out of the meetings. And I thought what I might do is read you the title of the abstract and have you comment what you thought and how it might be important or practice changing. The first one was entitled, A Randomized, Double-Blind, Placebo-Controlled Study of venetoclax with azacitidine versus azacitidine alone in treatment-naive patients with acute myeloid leukemia ineligible for intensive therapy.
Yeah, Courtney DiNardo, I thought, did a really, really good job of presenting this late-breaking abstract. We've known, of course, in the US, venetoclax is, of course, already licensed for the treatment of AML. In Europe, it's still awaiting license, although interestingly, because of the COVID crisis, we are unexpectedly getting early access into this combination because, of course, it's a very attractive proposition to be offering to patients in the setting of COVID, where you want to avoid this setting. So we already knew that venetoclax looked as if it had very good efficacy in acute myeloid leukemia. And of course, the VIALE-A study series of studies this particular one looked at venetoclax plus azacitidine versus azacitidine plus placebo, and clearly met its primary endpoint in demonstrating very impressive improvement in progression-free survival. It clearly demonstrates, and remembering, of course, this is a group of patients in whom we've seen very little progress in their outcome for acute myeloid leukemia for decades. So advances that we see in this way really, really moving the field. All we need now is the oral azacitidine, and of course we saw the phase 1 and phase 2 trials coming out from that. So if we can get that combination and move to an oral combination for acute myeloid leukemia, I think the data was unequivocal in the elderly patient population that Courtney presented. And of course, the big question everyone has is it going to find a place, in younger patients, and how are we going to couple it with other things? Because pretty much at the moment, whatever you add to azacitidine venetoclax is really showing an improvement. But the azacitidine venetoclax combination looks particularly attractive.
Was this study de novo AML or perhaps seniors who had MDS?
This was de novo AML, but there was, of course, a presentation at the meeting also on the MDS. Wasn't a late-breaking abstract. That was also presented. Also demonstrate, it was a much smaller study, earlier phase, not phase 3 randomized trial, but looking at this combination in the MDS population, also showing very, very promising results.
And this would have been the azacitidine that I'm familiar with in this setting is 5 or 7 days, and then the venetoclax 14 or 28 of the oral venetoclax.
It was a 28-day cycle, venetoclax continuous. The azacitidine, I think, was 7 days in this particular setting that Courtney presented.
Well, I think that's continues to be practice changing for our seniors, and it's morphing into the seniors who come to the table MDS to AML. So that's one that I'm going to check off and watch. Next one I was intrigued by, I think this might have been also a late breaker. I'll read the title. phase 2 randomized clinical trial comparing ropeginterferon versus phlebotomy in low-risk patients with polycythemia vera, results of the pre-planned interim analysis. So I keep, I think all of the Italian data where hematocrits of 45 and higher in men and 42% and higher in women, you better keep them down. So I do that a lot. And this looks like this might be another option. Did that turn out well?
Yeah, it was an interesting presentation. And of course, funnily enough, I missed a little bit of it because I was online behind the scenes.
You're a little busy.
I was a little busy chairing this one. So I saw bits of it, and I saw what I thought were the headlines of it. And I saw Professor Babui answering the questions. You're absolutely right. It gives another option. But it also, of course, demonstrates that sometimes the old-fashioned phlebotomy can also be quite efficient in these circumstances, and everything is about weighing up risks and benefit for this particular type of population. So it's interesting thing, and whether or not, particularly in Europe in a more managed market, people are going to think that the cost effectiveness in terms of the benefit of using the interferon is going to be, a way forward that's actually going to really change practices is something that came up in the discussion. What is clearly the case, of course, is that pegylating the interferon leads to a very different profile in terms of the side effect profile that you're going to see, which is the really big thing. I mean, you and I have used interferon a lot, and
and they don't come back.
You can mimic lots of the symptoms of COVID-19 very quickly with the old-fashioned interferon. So I thought this was a very interesting approach.
Well, so that's not approved in the States either, but something as it develops, it will be another option, because the phlebotomy may not be everyone's favorite, and something that
absolutely.
Outpatient might be different. All right, another one to discuss. This goes over then to myeloma. The abstract entitled is Cetuximab plus carfilzomib and dexamethasone versus carfilzomib and dexamethasone alone in relapsed refractory multiple myeloma, interim analysis of a phase 3 randomized open label trial. And the cetuximab, is that another CD38 antibody? So it's
exactly another CD38, and sure we'll come back and talk about that in just a moment. So Philippe Moreau presented the data for this interim analysis from the Data Safety Monitoring Committee. Actually stopped the study to say that the study had met its primary endpoint, and that the addition of the inatuximab to the carfilzomib dexamethasone backbone clearly demonstrated superiority in outcome in terms of progression-free survival. Very, very clear-cut data. The discussion, of course, sits around where does this fit via daratumumab, and I don't think any of the patients on this study had a previous CD38 antibody, so we don't know whether this is going to be something that can be useful in somebody who's already had a previous anti-CD38. There's a lot of questions from the audience came in on that thing that you probably are most interested in, that is, how does this stack up against a daratumumab?
Yes, yeah.
So we have got the Candor study from before, which previously led to the approval of daratumumab in this setting. And of course, Philippe talked a lot about how the patient population wasn't really exactly the same, but it looks quite easy to say that it's similar in efficacy. Big issue now, of course, is we've got daratumumab subcutaneously versus the intravenous use still of inatuximab. So, but very clearly demonstrating, as we've seen in diffuse large B-cell lymphoma and follicular lymphoma in the past, the addition of an antibody into triplet therapy for multiple myeloma, clearly an advance, and surely moving into frontline, and we'll see where we go from there.
Yeah, and as you suggest, we have in the States first-line approval for a daratumumab combination. I think you can do it with DRD, with Revlimid, lenalidomide, or even if you want to do proteasome inhibitor, that's in the front line as well. So you have kind of mix and match in the front line setting.
We have the same here in Europe. So same approval, so frontline. And we've just now got released the subcutaneous formulation, which
same here.
We've only had access to before inside clinical trials, clearly leading to a decrease in the infusion-related reactions, which of course have been a problem before. Those, of course, were reportedly in an inotuzumab study, but it did look as if the infusion-related reactions weren't quite as severe with intravenous inotuzumab as they were in the early days of the daratumumab. So we'll see where that goes. But choices for our patient is what these are all about. And, people now have another CD38 antibody to consider as part of their armamentarium.
Yeah, the progress continues. So, of course, this is all happening to us because of COVID, so we would be remiss if we didn't mention a nice abstract entitled Endotheliopathy is Essential in COVID-19 Associated Coagulopathy. So you, like us, have been seeing strange coagulopathy, low-grade DIC, sometimes even more vicious DIC. And I've kind of heard one of our thought leaders in coagulation here in the States say, well, think of it, maybe it's like HIT antibodies. So we used to think heparin causes thrombocytopenia. You stop the heparin, you're all good. Well, then those patients go on to clot because of the antibody for maybe 2, 3, 4 weeks. And so we're wondering, and perhaps this abstract sheds some light, is it the virus itself that's causing endothelial upset and coagulation follows, or maybe the antibody you make against it? Or we've had cases in the States, one of our Broadway stars lost a leg out of nowhere, COVID positive, and he lost a leg. And we've had another athlete, some 30 years old, highly trained pulmonary embolus. So do you recall what they found in this particular study?
Yeah, I thought this was a beautifully presented abstract. It's a fellow from Yale, I thought, who gave a beautiful talk on, which actually a very complicated field, but I thought he gave a very nice presentation. For those of you who've still got access to the platform, remember it's still up till October 15th, so there's plenty of time to go back and look at it again.
Yeah.
And I'd highly commend people to go in and look at that talk, because I thought he gave a wonderful presentation. And you're right. So what they found was that those patients who were severely ill with COVID, in particular those patients who landed up in ICU within the Yale system, they found very clear evidence of endothelial damage contributing towards the coagulopathy. And I think you're right. The picture would appear to be one that it's not a direct damage from the virus itself, but a secondary event occurring in some indirect, probably immune-mediated mechanism. They're still working hard on precisely what that etiology is, but the data that there was evidence of endotheliopathy, that is damage to the endothelium, alteration in von Willebrand factor and other issues causing the procoagulant effects, very, very nicely worked out and very nicely presented. We had a whole series of COVID-19 focused talks. We actually had a special call for COVID, and this one got into the symposium in response to the special call we put out for COVID. In one of the plenary lectures, Martina Muckenthaler from Heidelberg, her field is in iron metabolism, and you think, what's that got to do with COVID? But she gave a beautiful presentation on the work that they've been doing, looking at the impact of COVID-19 on iron metabolism and how that perturbs that system. And a little bit surprising effect was demonstrating how that led to polarization of macrophages into M1 type macrophages, increasing the inflammatory circumstances. So you can imagine a whole cascade of events that this virus triggers off, and you could tie those issues together. So we've seen a whole series of talks on people really trying to get to the bottom of how exactly this virus induces such incredibly diverse types of symptoms, particularly related to our field in hematology.
And would you mention her name again? Because we'll put that abstract on the
website. Sure. Martina Muckenthaler from Heidelberg. It's one of the plenary presentations.
Terrific. Well, then I
the
think
the plenary 2 session.
Plenary 2. Whoa. Plenary 1 and plenary 2. Wow. Yeah. It reminds me to ask you, what your particular area of interest, or clinical or scientific research, what is your area of interest?
So my area of interest is in the lymphoid malignancies, but my particular area of interest is in the immunological impact. So we used originally looking at what was the impact of cancer on the immune system, and now, of course, about how can we reverse that and how can we look to do it. So the whole field of CAR T cells, how we exploit the immune system to tackle cancers.
Well, let me ask you then, I sat in the front row at ASH in December in Orlando when Steve Schuster, I think it was Plenary, talked about lymphomas that had progressed beyond CAR T and a bispecific antibody that worked in a surprising percentage of patients. Was anything discussed at this EHA meeting?
Yeah, we had lots of talks on bispecific antibodies. A very nice session there. A big question for lots of us is, CAR T cells versus bispecific antibodies. Which is the approach? We've got a long-lasting, very expensive therapy versus a slightly less expensive therapy you can repeat over and over again. And are they complementary? And of course, the potential to be thinking about using bispecifics, of course, can target any of the antigens on the surface of any of the cells. So I think all of that field is demonstrating to us that after 100 years of talking about how the immune system can really do something against cancer and lots of false starts, we're certainly seeing now all the promise that it has to offer. You talked a minute ago about COVID. The issue with all of them is, of course, the cytokine release type syndromes, which, of course, we've all used to now seeing with COVID. But as we saw that in our COVID patients, we're very reminded of the sorts of things we see with our CAR T and our bispecific antibody, and even our antibody infusion patients, where they get the CRS type effect with the first infusion. So very similar kind of pathophysiology.
Interesting you mentioned that. It made big evening lay press news in the States this week. New medication found by investigators. I'm trying to think where that was, but it was if you're seriously ill, they gave this new drug, dexamethasone.
Well, that's actually it's an English study, so
it is an English study, isn't it?
It is an English study, So dexamethasone. So of course I was busy thinking that. Of course, when we see CRS in the immunology field with our cancer patients, one of the first things we go to is dexamethasone. So I was wondering why it hadn't been done earlier. A big issue there, of course, is about when you give it. If you give high doses of steroids when the virus is causing the problems, you run the risk of suppressing the immune response. So it's about getting an appropriate immune response and then dampening it that looks to be beneficial. But the impact on mortality on the addition of dexamethasone was quite impressive. I think a 20% reduction.
It was quite impressive. I think actually our news and press were pretty careful to be correct, because you don't want to run on dexamethasone in the drugstore. Everybody's going to take it to prevent.
We had for hydroxychloroquine, right?
Exactly right. I have a little bottle still at home. So, well, I can't thank you enough for taking the time. It's evening where you are in Europe and London, so I really appreciate it, John. And I want to remind our listeners you've been listening to Professor John Gribben, who is Professor of Medical Oncology at Barts in London and the reigning President of the EHA European Hematology Association. And congratulations on a wonderful meeting. Sounds like it was successful, and our listeners can go to the website until October to listen to presentations. Sure. So thank you very much for joining us, and we will remind everyone we are online at mdedge.com/hematology-oncology, a WebMD and a Medscape journal, and we thank you very much for listening.